Morning, everyone. My group members are Michael, Thomas, Yazan, and myself, and our project is on the field expedient pelvic splint for tactical combat casualty care. Pelvic ring fracture is a high energy injury that can come about as a result of sudden impact to the pelvis. This diagram here shows a variety of pelvic fractures, including ring fractures. The main contributor to mortality in these injuries is the risk of internal bleeding. Since it takes a lot of force to cause a pelvic ring fracture, there is often other serious damage to regions like the spine. In an analysis of pelvic fracture incidents, it was found that incidents were mostly split between the elderly population and active duty military members. One of the leading causes of fracture in the latter case being improvised explosive devices. Next slide. In a combat situation, it is likely that soldiers who sustain a pelvic ring fracture will not have speedy access to hospitals for surgical intervention. So a solution is needed to reduce the risk of internal bleeding en route to the hospital for long-term treatments like surgically fashioned screws and plates. Next slide. Devices called pelvic circumferential compression devices, or PCCDs, can help stabilize the pelvis and reduce internal bleeding. 3 examples of commercially available devices are shown on the right. The middle example, the SAM sling, which we recently acquired, is the PCCD carried by all U.S. Army medics.
So this brings us to our problem statement. Currently, Army medics carry only one pelvic binder in their medic packs. There needs to be alternative means of treatment that uses materials common to all Army packs, not just those medic packs, provides non-invasive reduction of open book pelvic fractures, and is viable for long-term field care. So after our problem statement, we have our needs assessment. On the patient, our injured soldier side, we need to be able to provide adequate compression to the injury to reduce the internal trauma and internal bleeding associated with the injury. We need to have it available for extended field care because missions often take place in remote locations under uncertain timetables. Treatment at a long-term facility might be hours or days away. And it needs to be non-invasive, just given the environment soldiers will be immersed in to have the best results. For the provider or the medic, we need to be able to have them treat multiple injuries because IEDs often target more than just one soldier. It needs to be easily and quickly applied so that the internal bleeding risk is minimized, and just given the potential incoming fire or other hostilities soldiers may be facing. We need to have it available for adjustable sizing because of the different body types and equipment soldiers may carry. And we need to have stable fastening so that as the injured is moved from the point of injury to the point of long-term field care, we don't exacerbate the injury any more than it already is. On the system side, we need to have our solution be lightweight and portable, fitting in a medic pack such as the one pictured here. And it needs to be affordable and widely available just so that it can be implemented easily. Next slide. So this brings us to our solution. Our solution is an improvised method comprised of the SAM splint and cat tourniquet, both of which are very common to all medic packs. So we begin by unfurling the SAM splint, folding it back on either side, and then making a small incision 1 inch from each side. Then we thread the cat tourniquet through it with the folds situated inwards so that as it goes around the body, folds are inwards. And then we place it over the greater trochanters and tighten. Next slide.
So as for testing our actual device, we primarily used a mechanical tester with customized attachments. This mechanical tester allowed us to apply forces onto our our device also allowed us to measure the force that our device applied onto the attachments. And this gave us some approximation as to what the compressive force of the device on the renal pelvis would be. Could you go to the next slide? So our customized attachments, the ones that were attached to the mechanical tester, were composed of these stacked 1/4-inch medium density fiber boards, as you can see on the right. And we did this so it can resemble the pelvis. Another component that we also designed was this wishbone attachment that's attached to the stacked glued together MDFs. This wishbone attachment allows us to attach the fireboard onto the mechanical tester. And then, actually, could you go to the next slide? And then, as you can see in this slide, this is our full mechanical tester setup. We have the attachments attached to the mechanical tester, and then we have the SAM splint attached to the pelvic attachments. And we also made sure they were about 4 centimeters away, and that's kind of to make sure it resembled the pelvic region of the human body. We also, the figure on the right shows our improvised method, but we also use the SAM splint to compare 2 sets of data. Could you go to the next slide?
So here we have results from these mechanical testing experiments. And so as Yasan mentioned, we compared our design, the field exceeding pelvic splint, to a commercial pelvic binder, the SAM sling. And that's shown in the figure on the right. And so our device, the FEPS, has multiple levels that you can crank our device to. So because ours is comprised of a SAM splint and a cat tourniquet, the cat tourniquet has a windlass that can be cranked multiple times to generate varying forces. And so we measured the field exceeding pelvic splint with 1 crank of the cat, and we also measured it with 2 cranks of the cat. And so that's what's shown in the figure on the right. And so with 1 crank of the cat, we were able to generate forces that were substantially equivalent to those generated by the SAM sling, and that's represented by the non-significant statistical significance. And then we also cranked it with 2 cranks of the windlass on the cat tourniquet, and that generated forces that were much greater than those generated by the SAM sling, showing that our device is more than capable of generating equivalent forces that are required to adequately compress the pelvis. And so that's why on the figure on the right, we see a much greater statistically significant force generated with the 2 cat cranks. And the error bars on this figure all represent 95% confidence intervals, and we ran 3 trials on each of these. And so overall, this suggests that our design, the field expedient pelvic splint, is able to generate adequate compression forces that are needed to achieve full reduction of open book pelvic ring fractures. So we also looked at the generation of forces under longer term periods. So as Michael mentioned, that sometimes these splints will have to be on for hours or even up to a day. And so we looked at the force characteristics of our field expedient pelvic splint over a time course of 8 hours. As you can see, the force that is generated by the splint declines over time. And this suggests that clinically the field expedient pelvic splint will need to be tightened or reassessed every 5 to 6 hours when the force drops below the approximately 200-ish newtons that the commercial device, the SAM sling, is able to generate. And so we were only able to get 1 replicate of this experiment so far. We plan on performing additional experiments, and so we hope to have a more definitive answer to that in the coming weeks. Another aspect of our project is looking at the pressure characteristics of our device. And so we are using a force sensor array to do that. So we acquired a force sensor array and a silicone pelvis model that's used to mimic the skin material properties. And so we are going to apply our binders to this silicone pelvis and determine the pressure at the skin binder interface using this pressure sensor. And so the reason we're doing this is because tissue damage, so tissue necrosis and or pressure ulcers, can occur when there's a pressure at the skin of approximately 9.3 kilopascals. And so since our device is a more improvised device, we're trying to compare our device to the SAM sling and see if our design generates much larger forces, since we do have a slightly larger, we have larger forces generated with our device. And so we're trying to see if our device is going to cause tissue damage, or maybe this is an additional clinical consideration for combat medics to take into account when they're applying the device, and maybe they have to reassess patients every so hours to look for tissue damage or necrosis. And these experiments are still in progress. And so, as we mentioned, we're going to perform additional longitudinal experiments on the FEPS efficacy in the prolonged field environment, so over the course of several hours. And we're also looking at collecting data on the pressure generated by our device, the skin-minder interface. So thank you very much for watching our presentation. Here are references. Thank you.